First of all, thank you, Dr. Ratna, for your kind words. Dr. Charudat, of course, and Dr. Madhuri. Sometimes I wonder to have such an illustrious panel over here makes the speaker a bit jittery. Um, to have such a fantastic audience at the moment, the number really does not matter as long as you feel that whoever is there, you'd be able to add value to them. And I would like to speak about male fertility for a gynecologist. And I've tried to squeeze in so many things together. So this is just the first slide which I wanted to place about COVID. And there are a lot of things which have come up at the markers of inflammation and oxidative stress in sperms has increased in COVID. And COVID transmission too has been seen. And if you ask me very honestly, the number of papers which have come out in COVID have come out in COVID also because that was the only research which was going on particularly. Now, this is a very interesting slide, and this is a very interesting slide because it just gives us the idea of male fertility or infertility the way it is. And this is a 2004 in WHO got out the data which was presently, which they got out the data. Just a minute, I'll just put the display setting on. In which they found that out of 186 million people, 93 million male factor infertility was there, 93 million. And in these 93 million, about 50%, which is 46.5 million, were unknown or unexplained infertility, and about 50% of that was idiopathic. And out of this idiopathic infertility where the sperm count is normal, there is no problem in the sperm parameter, the woman is absolutely normal, about 80% was oxidative stress. So if you look at the whole scenario of infertile people, 50% because of the male, and is the 50% of this would be known or unexplained, and 50% is going to be idiopathic. In this whole lecture, I have about 5 points to talk about, and the learning objective would be that WHO has updated, which I'll talk about, new diagnostic tests which need to be used by gynecologists, antioxidant supplementation today has become a very hot issue, and to learn about azoospermia, and of course, the future the way it's going to be. So we all know that the WHO has been updating, and the latest update which has come, which is a massive update, has gone into the functionality of the sperm as well. However, every gynecologist should know one small thing, that the volume is 1.5 ml and the sperm count is 15 ml, which actually is not normal and abnormal. It is just the 5th percentile. In fact, to judge a patient whether the sperm count is the reason for infertility, you need to judge the number as a percentile, which means whatever he has. Supposing the man has about 60%, then you'll understand that well, this man is on the percentile scale about 60 or 50% of the percentile. Another important thing in the WHO criteria is the Kruger's criteria for morphology. So this is interesting because even till date, most of the patients which we get in the normal reports, none of the testing has been done by Kruger because it takes time, it takes a lot of effort, and people don't normally do it. So in case it has been done in the other fashion, it is best to get the sample repeated. So the focus again, I am speaking about the 5th percentile which we have to understand. So please do not take any sperm report as normal or abnormal based on the report which you're getting, and just please consider it as a percentile. Now let me go on to the things we need to even look into as the functionality of the sperm. So I'll keep the other tests away, but probably something I'd like to speak about is sperm DNA integrity, reactive oxygen species, and Y-chromosome microdeletion, which clinically become very relevant for all of us. So this was a beautiful review article of which I was a part, and a massive review article on DNA fragmentation, of course headed by Dr. Ashok Agrawal. And the background of this is that normal sperm chromatin is essential for paternal genetic transmission. Unexplained infertility, recurrent pregnancy loss, poor outcomes of IUI and IVF become a reason to get this test done. Quantification of sperm DNA strand breaks is what we do. The sample is semen or spermatozoa, and the techniques are the nucleotide direct assessment and nucleomatrix assays. This is a summary from this paper that anyone for SDF, any one of the following assays can be used which I have talked about. The cutoff varies from different laboratories, but 20% has been used to distinguish fertile from infertile men. The cutoff values for prediction of various pregnancy outcomes differ according to various factors, but adverse outcomes are generally associated with levels above 20 to 30%. Testing of SDF should be done after 2 to 5 days of ejaculatory abstinence, and SDF tests should be performed within 30 to 60 minutes after liquefaction or immediately after thawing. Now this brings us to a beautiful area that a lot of laboratories today are taking your samples from your clinic for sperm DNA testing, which cannot be done because you either need a fresh semen or you need a frozen semen. You cannot carry a semen in liquid CO2 and give an SDF report. So a lot of laboratories have nowadays started, and you just cannot do it that way. That's the issue with this particular test. Now, what are the indications of SDF? Unexplained or idiopathic male infertility, recurrent pregnancy loss, clinical varicoceles, lifestyle risk factors, before or after failure of ART, IUI, IVF, ICSI, recurrent pregnancy loss after ICSI, sperm freezing. A lot of times we do an SDF before any sperm freezing which we normally need to do, unless and until it's a cancer patient going on to chemotherapy, because you have no option at that time. And the management is very, very simple: a lifestyle advice and modification, use of antioxidants, recurrent ejaculation, treatment of underlying condition as varicocele, antibiotics. Recurrent ejaculation is a very beautiful procedure which we normally use. In fact, at times, you are really able to get a better sample by recurrent ejaculations. The use of ICSI if SDF is persistently elevated, and another method of sperm selection after a failed ICSI, testicular sperm for a failed ICSI. This is a beautiful algorithm which is in another paper which we've had as a guideline for clinicians. And if there's an infertile couple, you do an evaluation, you find that there is unexplained or idiopathic infertility. I don't have the time, but because I could beautifully explain you the difference and diagnosis of unexplained and idiopathic infertility, which are different. And recurrent miscarriage, lifestyle factors, varicocele, IVF. You do an SDF. If the SDF is high, you go on to recurrent ejaculation, antioxidants, lifestyle modification, control of infection or inflammation, varicocele surgery. If the SDF still persists, you could go ahead for an ICSI. If with ICSI you have recurrent miscarriages, then you should think about a testicular sperm or sperm source processing in a different fashion. This is a beautiful slide which I have taken from Sandro, and this is the study which he had, that live birth rates with IUI with SDF high is about 1.5% only, and even the IVF rates or the IVF pregnancy rates are low. Now, why does it happen that in ICSI you have pregnancy rates? Have you selected the sperm? No, not really. The reason is simple, that the repair of the DNA takes place by the cytoplasm of the oocyte. And this repair is done better if the woman is young. So in case the sperm DNA fragmentation is high and the woman is young, the chances of having a successful pregnancy without, I would say, a miscarriage is higher. So I always tell my patients that in this race, if the woman is strong, she will carry you. And if the man is very good, then the woman could be carried too. So this becomes very important for explaining to the patients. Now, what we normally do in our laboratories most of the times is the halo test, but a lot of other tests which are available, in case it is possible, then they should be done. Y-chromosome microdeletion, I speak particularly because if there's a patient who comes with a sperm count less than 5 million, if there is an azoospermic who's come to you, please get a Y-chromosome microdeletion done, for the prime reason that in case the deletion is in the AZA area or the AZB area, there'll be no sperm, so there is no point of going ahead and doing a retrieval. And in case it is in the AZC area, you need to do the retrieval, but with the counseling of the patient that, well, if a boy is born, he's going to have the same problem. I'm going to tell you a very interesting thing about a patient, and this story is very interesting. They came to us about 9 years back, and they came to us when they had no children. He had Y-chromosome microdeletion, did a retrieval, had 2 daughters. 7 years after that, he came to us and said that, well, I want to try again. I told him very, very specifically that, well, in case a boy is born, you're lucky you have 2 daughters. If a boy is born, he would have the same problem. He said, no, I want to try again. Fine. We did an ICSI again, and this time he got pregnant again with twins and had a boy and a girl. And when I asked him, why did you put in so much of an effort? You know what he said, which was so beautiful, because human beings are so beautiful. He said, कि अगर मेरे बेटा आज हो सकता है, जब इसके बच्चों का टाइम आएगा कुछ और निकल जाएगा. So the beauty about the procedure is you need to do what the patient wants, but you need to do it ethically after explaining everything to him. Antioxidants, well, a lot of people, including me, about 10 years back used to think they are placebos, till the time it was understood very clearly that the global, I was a part of this global survey of clinical utility of oxidative stress testing and antioxidant use. And there were about, in this study, about 9,500 clinicians who were in this massive study, whose input was taken in the survey. And the classification and the use out of all the papers which are there today is the enzymatic. I would say that non-enzymatic would be vitamin C, vitamin E, ferritin, carnitines, coenzyme Q, transferrin, zinc, selenium, N-acetyl-L-cysteine, L-arginine, folic acid. All of them are working at different areas of the sperm biomics. And the question normally asked is, what do you need to use? So whatever you use, at least I particularly use 2 vitamins always, along with anything else you want to do, vitamin C and vitamin E. One is, I would say, water soluble. And the result is that normally if you add both these, which are very cheap, the results which you get are better once you have cleared the infection, and in case there is anything else in the lifestyle modification which needs to be done. This is normally the combination which I give to most of the patients. Interesting case we had. I bring these cases because they are very, very important even for me, the way I look at it. Azoospermic, I would say, immotile sperms, not a single sperm which was motile. I told him that there is no sperm which is motile. Did a horse test, did not find any viability in these sperms. Told him that, well, I do not think we'll be able to get a sperm from you. Said, is anything possible for me to do? We gave him antioxidants for about 4 months, 5 months, and we found a few viable sperms. But the problem with me is that I have personally, I give all the options to the patient, and I tell them honestly, very transparently, this is what we can do, this is what we can't do. And they had children. I do not say it always happens, but at least I know one thing for sure, that antioxidants, if used judiciously, have a role which needs to be done. Now, azoospermics, 70% of azoospermics can have their own babies. There's a paucity of time. I'll be very quick in whatever I would go in. If you divide it into 2 areas, it could be obstructive and non-obstructive. We all know what obstructive, non-obstructive is. Different techniques are available. I just have a few videos which I'd like to show. So, PISA is a very simple procedure, but in this PISA procedure, there are 3 things which we need to understand. You can have a very good retrieval in the first go itself, as long as you see the fullness of the epididymis and feel it. Once you have felt the epididymis, you go on to and get hold of the most full area of the epididymis. You could use a BD syringe with media in it. In the center of the swelling, if you go. Now, these, if you get this sample, And if it is positive, which normally would be positive in most of the patients who have an absent vas or have had infection and funiculitis in the vas, you would normally get sperms in that. In fact, now at times what happens is you do not get it in a PISA where the sperms are less. So in this you would normally like to use a butterfly, and you will use a butterfly with a 10 ml syringe. 20 is wrong, which is written over here, with a 10 ml syringe. You do this because of the prime reason that your suction is better, and you would have some media which is there in the tubing. Now this media in the tubing, and the moment you have done the suction, you would normally just clamp the tube and use this to see if sperms are retrievable. Obstructive azoospermia. Now there's another procedure which I normally do, and I do where I would like to have a lot. This is, just a minute. There is another procedure which I normally do, and in these patients I do a MESA procedure, especially if I want a lot of sperms. And how I have modified it is that after opening up the epididymis under a microscope, I would get hold of the epididymal tubule, which is the thickest, and in this tube I would put in what is known as a micro-catheter and do a suction with it. So what actually happens is that I don't have to at times suture wag the epididymal tubule, because the micro-catheter is such that the hole made by it normally heals by itself. Now, in case you have done a PISA, you think it's obstructive azoospermia, in case you think that this man is having hypospermatogenesis, earlier sperm has been retrieved, you normally would not do a Micro-TESE, you would just take a small specimen by a window technique. But in case in the window technique you do not get a sperm, what you normally would do is open up the whole testes if you're not doing a Micro-TESE. And once you've opened up the testes, you would take biopsies 4 above the equator, 4 below the equator. And once you've taken 4 above the equator and 4 below the equator, you're in an area where you are able to get different areas of this testes. And once you have taken this specimen, especially non-obstructive azoospermia, I used to do it very earlier when I didn't do the Micro-TESE. This is a very old video. It's about an 8 or a 9-year-old video. But I've just placed this video because I want to show you, if you're not doing a Micro-TESE, you could go ahead and do this procedure. Now, Micro-TESE is a beautiful procedure I've done well. There are 3 important things which I always say, because a lot of people ask me, how can we do Micro-TESE? Number 1, you've got to learn microsurgery. Microsurgery is very different. Microsurgery is not like laparoscopic surgery. Microsurgery is not like the surgery we normally do. It is just like you're doing an ICSI kind of a procedure with a microscope and using your hands in a different fashion altogether. So in case you are fine with microsurgery, you would like to have a good microscope, operate between 16x and 25x. The dictum is, once you have opened the testes and you're seeing the testes, I'll just put on the video. So we normally would do it in 3 planes. The first plane would be that the moment we open the testes, we would like to take, in case you find over there areas and tubules which are different from the tubules otherwise, thicker tubules, at times tubules which have, I would say, a yellowish tint, which you see at times under a microscope, especially if you put on the green filter in them. And once you find in the first, and you send them to the laboratory, you would normally need 2 stations where people are working simultaneously. Once you get from this specimen a sample, the day is done. But in case you do not get from this specimen, this is the time we normally would bivalve the testes. Now, bivalving the testes means that the moment you put in pressure and pull apart the testes, the whole testes actually opens up like this. And once it opens up like this, you're able to take specimens from different areas, and these specimens which you take from different areas would be tested to see if sperms are present. So a testes, once it has been bivalved, can be stitched beautifully, specimens would be sent, and sperms would be retrieved. Now, this is how it actually appears under a microscope. If I would like to take the microscopic picture, you can see this tubule is thicker than the rest of the tubules present. So this is the tubule which we would take, and would be processed to see if any sperms are present. Now, this is just a sample of a PISA sample. And in this PISA sample, you can see RBCs, you can see debris, and you can see sperms which are present. And it's a reasonably good sample. So you can get a lot of sperms, lot of viable sperms to be used, as well as sperms which you would like to store and freeze. Now, this is a patient I'll talk to you about. This is an interesting patient which I had, and 14 years back. Very rich lady, I had known her for a long time. And she came to me, to my clinic, and said, I want the most expensive sperm available in the world. So I looked at her and didn't understand really. Then I realized after some time she told me it's my son, who was diagnosed as hypogonadotrophic hypogonadism when he was 16 years of age. But she felt that the doctor was cheating her and wanted to use too many hormones, so she didn't get any treatment done, got him married, came to us, realized he had, this is 14 years back, realized he had small testes, low FSH. So I spoke to her and I said, I do not know about the most expensive, but if possible, I think I could get the best sperm for you. And started them on hormones, and finally transferred about 3 embryos, did a fetal reduction. Finally, he had 2 children. Similarly, this was the first case which we did of post-cancer survivors with azoospermia, non-obstructive azoospermia. I think the children now must be about 8 years age. But you know what has happened? I'll just share with you. Any procedure which you do, any procedure, you develop over a period of time, and every successful case gives you the impetus to do better. And it boosts your confidence that this is possible in which you can do. And this is exactly the way it is for the brilliance of the future. I hope I'm on time. I have some time? No? Okay, I'll just wind it up fast. I'll just talk about, see, let's understand one small thing. Spermatogonial stem cells, if taken out, in mice have been cultured into sperms. These sperms have been micro-inseminated and mice have been born. Now in humans the problem are 2. Number 1, to excise spermatogonial stem cells, you'll have to take a lot of tissue from the male testes, which may lead to a testosterone level which is low first. And the second problem is that culture systems till date have not been developed. But if with a lesser specimen sperms could be made, then even though non-obstructive azoospermias where Micro-TESE is not possible, you probably could get your own sperms. Now the future prospects would be transplantation of the testes into a rat to grow them. There could be xenotransplantation, there could be auto-transplantation. In the future, by genomics, we probably could know the kind of markers which would tell us what is the chances that retrieval would take place. And of course, in vitro regeneration of sperms. I had spoken to you about it. CRISPR, of course, I don't have time, otherwise I'll explain something beautiful about CRISPR. But the only thing which I'd say is, and I always bring this slide, because it always makes my mind run in a different fashion. Boy, boy, girl, girl can marry. And why should they not? But can they have children of their own genome? Till now, you had one donation. But in the future, if a pluripotent stem cell could be taken from a male, converted into an oocyte, and a sperm could be taken from the other man, kept in a surrogate, they could have their own child. And similarly for a woman whose pluripotent stem cell could be made into a sperm and one oocyte taken from one of them, and one of the women could become the mother, gestational mother, they could have their own child. The future in reproductive science, I feel in the next 20 years, will be just magic. The way metaverse is going to change the way we use our phones. We may not use our phones 10 years from now, for that matter. And probably if I have to talk to Parsuram, I probably would have him standing over here in different cities. Similarly, that's the way probably this technology would be. And I thank you very much for the kindness of giving me this time.
Thank you, Dr. Jindal, for such an excellent presentation. You nicely explained the oxidative stress following varicocele following infection and the role of different antioxidants. And you nicely demonstrated Micro-TESE, and you highlighted the recent advancement in male infertility. Thank you. Actually,
So
we are going
I
to
just
the...
want you to tell the audience, because it's very important to know, because there are many gynecologists in patients of azoospermia, and the FSH levels are very high, and yet are prescribed clomiphene citrate, tamoxifen, gonadotrophins. I think that needs, you need to give them a thing that all these are helpful only in those patients who have a low FSH and LH.
See,
And the time for which you need to give antioxidants, you cannot give them for years and years together.
you know, Dr. Madhuri always has a question which you need to wait for. And you need to wait for it because it's always pertinent. So where would you give clomiphene, where would you give medical treatment is important. With a very high FSH, there is, see, just understand. Why would you give clomiphene? You would give clomiphene to increase the intratesticular testosterone. Simple. Where would you increase the intratesticular testosterone? In any patient who has a subnormal testosterone or a testosterone which is low normal. How would you increase testosterone? It will be depending on the whole hormonal profile of the patient. You do not give any testosterone supplement, which means testosterone, to any man in the form of capsule or injection, because it is counterproductive and it does not increase the intratesticular testosterone. Whenever you inject or give a testosterone from outside, it increases the serum testosterone, which decreases the LH, which decreases the intratesticular testosterone. Clomiphene is to be given in those people where before retrieval, if you find, I'm talking of azoospermics, before retrieval you find that the testosterone is down. That's the only place where clomiphene will be given.
No, moreover, basically, we need to give these drugs only when the FSH and LH levels are normal.
No,
even clomiphene citrate,
no,
if
no, madam.
the level, I mean, if the FSH is very
No,
high,
I'll just
CC
bring,
will not.
Yes. No. In case the FSH is high, it's a non-obstructive azoospermia, and the testosterone is down.
No, not only in azoospermia, I'm saying, even in oligospermia or the other things.
Yeah.
So in these patients, usually, if you take a oligospermic, there's so many times you get a prescription from a gynecologist prescribing 25 milligrams of CC, yes, but they've not looked at the FSH. So if you look at the literature, it also says that unless the FSH is on the lower side, your clomiphene citrate is also not going to act.
Madam, we're giving clomiphene citrate for only one role, and we're giving at this moment to increase the intratesticular testosterone.
Yeah. But I'm talking about the general gynecologist, yes, what they prescribe. So they need to know when it should be prescribed and when it should not be prescribed. Yeah, and there are many who are also giving testosterone injections to males. Yes. And that, on the contrary, is going to reduce, yes, your sperm count further.
In fact, it just should not be given. And antioxidants, if given, need to be given for a minimum of 3 to 4 months. You can continue them in case you have done an STF and you're seeing that the STF is going down. Now, supposing in case you're doing that testing, if you're not doing that testing that well, you need to give them antioxidants for a long period of time. By long period of time, I do not mean that you would get a pregnancy by giving antioxidants for a year or so. But you need to document what is the reason that you're giving antioxidants to them.
And sometimes the role of antibiotic, especially in case of this recurrent infection, along with the antioxidant.
Right.
Yeah, but you need to differentiate. If you get a semen analysis done from a normal lab, they might just report the premature germ cells as WBCs. So it's very important to differentiate between the premature germ cells and WBCs, because people are given doses of antibiotics again and again, just looking at the premature germ cells and thinking that it's a WBC.
Then you have to do the peroxidase staining method.
Yeah, so I think it's important that you need to, yes, also differentiate that. And when they're giving gonadotrophins in patients with non-obstructive azoospermia, so you should always expect a result only after about 5 to 6 or 7 months, because that's what is a time interval.
Normally the timing would be, see, whenever I would normally give gonadotrophin to a man of non-obstructive azoospermia, I do three things. First thing is I counsel the patient and tell them that I'm going to give you this gonadotrophin for at least 3 months. The second trick which I'm giving you, which nobody would give you, is most of the HCG we get, 5,000, contains about 2,500 or 3,000. It's not fully charged. I've got it tested so many times. And this is the reason that when you do not give Ovitril for rupture in an IUI, at times you have problems and eggs don't rupture because the amount of HCG in these vials is less. And so normally what I do is I give these patients, you need a dose about 2,500 twice a week. So what I normally give is I give them the 5,000 vial as it is, because what you normally contain in that is about 2,500. I would normally give this for about 3 months. And I would wait for two things. Number one, the increase in the testicular size. When you give HCG and you examine the patient, you would see an increase in the testicular size. The libido rises. So you've got to ask two things after examining them when they come after a month: the size of the testes and about their libido. Then the third thing happens is you can get the testosterone tested. And once the testosterone is over 300, that is when you can take them up for a micro-TESE.
Thank you, Dr. Jindal. Just one, not a question, one suggestion. In case of spermatocyl, though it is not very common, sometimes we are getting lot of sperms for IUI or even conventional IVF.
Correct.
Do you suggest that we should do that, or after an antioxidant therapy, we should do the treatment with the sperms from the spermatocyl, or during that time we should retrieve the sperm from the testis itself for the ICSI? Because they are supposed to be under high ROS within the spermatocyl.
Yes.
What is your suggestion,
Yes.
please?
The problem with spermatocyl, like Madam said, is that they are under high ROS. But they are under high ROS because of stasis, ma'am. That's the problem with them. And even if we give them antioxidant, those static sperms will have nothing, there will be no change in those static sperms. So the question is whether we should take those sperms out, freeze them, and use them for ICSI. Because normally the results of IUI with a spermatocyl sperm is not very good. And you would not like to take them out again and again. Or if you are giving, if the patient has not got pregnant with these sperms, then you can think of a testicular sperm after you have given antioxidants.
Thank you. Thank you,
Thank you,
Dr. Jindal.
Thank